I'm Mike Janssen from Denver, and I really appreciate being involved in this first symposium on arthroplasty. I was given the task to talk about the biomechanics, the rationale, and what we've now really learned regarding lumbar arthroplasty. Jack later is going to talk more about the FDA clinical data and outcomes, so that's not going to be part of my mission today. I am not an engineer, but I'll try to go over really what we've learned, where we're at, what the rationale is, to try to set the stage to change gears a little bit for some of the lumbar technology. How do I push play? Right here, right? Okay, and that's just when I hear we'll advance it. Okay, great, thanks. So I'd like to hit three topics: the history, the development, and the testing. And and again, I'm not an engineer, so let's just try to go through some of this. And my objectives are to really talk a little bit about why we do arthroplasty in the lumbar spine compared to fusion, at least what the rationale is, the biomechanics and the designs of the past technologies, some that went through FDA approval and some that did not make it. Just briefly, some of the clinical testing, and then just hit on it. When I operate on a patient for low back pain, I always try to tell my fellows operate on 4 Ps: pain, pathology, protoplasm, and personality. And when there's something that doesn't quite match, either the patient that's a little bit crazy but it's got pretty good pathology, or the patient has soft findings on the MRI scan, or the patient that's got other psychosocial factors, since we're operating primarily for pain, the outcome clearly is never the greatest. Now, what position do we fuse the spine in? And that's always an interesting debate. Do we fuse the patient historically with decades of experience in the way they sit on the table, or the limits of our current tubular technology, our percutaneous instruments, or do we put them in what we think is best for that segment? I always try to believe that there's 2 types of surgery when you do fusions. Either you're creating a deformity or you're correcting a deformity. And so you have to think about that way, because even though we're only doing one segment, sometimes I looked at it, and we saw some cases last night that we created a segmental flat back, and we know that we've created a deformity that's going to be a problem at the next level. Now, historically, from fusion data, we've seen a lot of these types of technologies, and the outcomes over time, regardless of them, have been fairly consistent. Many of them improve 95, 90% success rate, but the overall clinical improvement on most all of the clinical technologies for arthrodesis, about 2/3. Either 60% have good results, or 2/3 of them have returned to work, or 2/3 of them have overall patient satisfaction with a variety of different technologies that we've subsequently looked at. And I'm just looking because I think this. So what we found also is if you go all the way back to the 80s, there's about, we had about 2/3 good results, and then we went into the 90s and looked at a variety of different conclusions from either the Ray cage compared to the ALIF, posterior spinal fusions, the overall success rate when we looked at BMPs when we moved into that. But the success rate for clinical success was fairly consistent. The difference when we look at fusion versus arthroplasty is the primary measure of a fusion was fusion, and the primary measure of arthroplasty is function. So we've changed our standards of the way we look at these kinds of technologies for both fusions as well as arthroplasties over this whole cascade of about 2 or 3 decades of technology. Now, clearly there are clear-cut indications for fusion. And here's a classic example of a patient that's got a degenerative disease at 5'1", an isthmic spondylo with instability at 4'5", and these patients do well, and it's probably the standardized treatment is to offer these patients a stabilization. But over time, we've learned, even though our techniques have evolved and changed to minimally invasive, that there are concerns regarding the dissection, the treatment of the tissues, fusion disease, transitional segments, how the muscles react, adjacent pathologies. So we've seen a lot of our own complications over time regarding a lot of that. But I think the big difference mechanically between an arthroplasty and arthrodesis is this. It allows the patient to find their own center of balance over that reconstructed segment rather than locking them in that place for the rest of their life. And if you are going to do a fusion and lock them in that place, just remember that the overall sagittal balance and creating a deformity is extremely important. It's always a debate upon which of these is the best technology to do when you do a fusion, and different technologies from a T-lift to a PLIF to an A-lift to a lateral approach. But we see the same thing when we were studying all of these technologies, and they all went through different forms of FDA approval, and we'll kind of talk about that. It's interesting that despite all of these technologies, and the one between the two gentlemen was a Costwick device that looked like something that belonged on the front of my car. But anyway, a lot of these, there was only 3 of them that I think have met FDA approval in the United States, and only 2 of them on the market. Isn't that about right, Jack? So all of these, and we'll kind of just briefly talk a little bit about why. So what's the history of arthroplasty? Well, we heard a little bit earlier that there was some ideas back in the 50s to inject some silicone into the cadaveric specimens, into the Fernstrom balls. And then in about 2004, there was over 100 patents issued in the United States for restorations of disc disease for either implants, viscoelastic properties, and then by 2004, there was actually 15 companies or private companies focusing all of their assets on just this disc disease concept and how to maintain or put in arthroplasty devices. This is a list here of just some of the patents in the different companies, from about a little over a dozen artificial discs, a number of nucleus replacements, a number of minimally invasive. There was this flood of ideas of patenting all types of different ideas and partnering with surgeons to try to secure a landscape for the future for arthroplasty in the lumbar spine. That's just a diagram of a lot of different designs. And every surgeon that came up with a different design and a company that had a lot of money that thought they could change the world in arthroplasty was putting a lot of resources in these different technologies. We're only looking at it in retrospect now with 2 of them available in the United States. So it kind of started in this direction. We saw the Charité get approved and then the ProDisc. And then over time, we saw a lot of clinical trials that started with metal-on-metal devices, semi-constrained devices, devices like the Flexicor that were hooked together. Many of these companies spent a lot of money buying these technologies that never made it to market at all. And then you can kind of see how this has evolved, and there's only 2 of these that are currently USA approved, which is the Lumbar ProDisc and the ActiveL, as you see on that side. So what's the rationale before we get into the mechanics? Well, the rationale for this compared to fusion was to maintain motion and balance the segment, to potentially decrease adjacent level pathology and not preclude a patient from having a fusion in the future. Well, I think one of the pioneers was Terry Marnay here, and he really believed in a ball and socket type design, that it would control predictable motion. It wasn't normal physiological motion because we weren't putting this in a normal disc. We're putting this in a disease disc. And so the concept was we need to design something that would control the motion, and some sort of a ball and socket design would help with that. And one of the first was in the early 90s. He implanted just a little less than 100 of these technologies in about 64 patients. He let these patients, he stopped doing this because that wasn't well widely accepted in the 90s, and followed these patients over time. Now, this particular design was changed. That was called the first generation of 2 keels on a non-modular device. And so their findings really at 7 to 11 years is about 58 of these patients were followed up and all the implants were intact, the range of motion was maintained, and the overall patient satisfaction was fairly substantial. And those patients they were able to follow up, which was one of the studies that spearheaded us to get to the next level to run clinical trials in North America. And so I think that gives an overview kind of where this technology somewhat started. This is how it evolved. At first, there was implants that came along with 2 keels and it was moved to 1. The properties of the material was fairly consistent with a high-density polyethylene and a cobalt chrome alloy. And first generations were put in block, and then they designed these so that they could be put in modular, where you could put in the 2 implants and then eventually put in the polyethylene. And they were felt to be clinically proven without much change. So here's where we're at today. Now we'll talk a little bit more on the mechanics. We have modular devices, as you can see up there with the ProDisc, that are put in with the 2 metal implants, and then you as a surgeon can insert the polyethylene. We have an in-block device, which is FDA approved for the ActiveL, and now they are different fixations. The ProDisc has the keel, the ActiveL historically had the spikes, and Jack was telling me yesterday that the ActiveL in the last couple months also has a keel, which I think is the key to give primary fixation as a mode. There were some metal-on-metal prostheses that were evaluated. There were substantial concerns regarding the dissemination of particles and ions, or was this really a dry joint, and there was no synovial fluid? There were some issues of concerns of metal tolerances, and these particular 3 technologies across the board never were approved in the U.S. To be utilized despite running clinical trials. I wasn't involved in the Maverick. We started in this bottom one here that was a Flexicor that was acquired by Stryker and then never taken to market. The metal on polyethylene devices such as this, the cobalt chrome and the metal on polyethylene, is probably the most widely used in total joint arthroplasty, has decades of use experience, and in both the ProDisc, the Activell, and the Charité regarding osteolysis and ongoing. Now, most of these technologies have been evaluated with a variety of different wear testing parameters, and about 10 years ago, every spine meeting that we went to at every society, there was so many biomechanical analysis of looking at each of these implants and how they performed at the L5S1 level, the L4, L5 level, and Paul McAfee and his lab and his team had overwhelmed the podium of looking at a variety of different ways, and I'll just summarize a few of them. Many of them were evaluated to look at load versus displacement and try to come up with models that were similar to the different technologies, such as this, and you can see the load displacement. We did the same things, and then they would look at them from compression testings against load versus displacement, and then actually moved into the mechanics of ball and socket joints of how they performed in different capacities, since it was a whole new area for us to embark compared to what we have done historically from that of a fusion. And then the same with motion. And once these get to the different keys of motion, how the polyethylene did regarding load displacement were all part of the overall mechanics that were done in very complex settings. And the majority of them were all performed initially between the Charité and the ProDisc, looking at creep and polyethylene deformations, metal fractures, which really wasn't seen. And there was a lot more information than most of us really enjoyed watching from the podium when we were looking for clinical results from doing that. But Thomas Steffen helped me try to understand that from McGill University of looking at these different implants. You can study them on the left, really had everything to do with whether they were a fixed implant, like you can see at the top, or whether they were a fixed rotation implant that were small but had more predictability, or you could make a larger polyethylene that would give a larger motion and mimic the motion a little bit different with translation that also may retain some different levels of predictability. And you can see that's kind of the direction that we've moved to when you look at the different types of devices. My thought 10 years ago was we'll have all these portfolio devices like we talked about with cervical spine, and we'll have a clear understanding of which one works in different phases of the disease, just like a total elbow or total knee, that each one works. Unfortunately, that never happened. I kept thinking, and as I was even watched this morning lectures for which of all these different implants, that maybe this one would work good in this phase of the disease, and this one would work good with kyphosis, and this one would work good when they have horizontal translation of the facet joints. But unfortunately, we don't have that. Despite having a decade of data, we really haven't been able to refine any of these. What we really find is we're controlling motion in a disease segment, such as this. And you can see that the axis of rotation stays fairly flexed, and if you do a really good job at a release, in theory, you should be unloading the facet joints rather than translating on them, and you control the fixed motion. The big things we don't understand is how much motion is appropriate and where should the axis be, and we also realize which phase of the disease are we putting this in, and does the patient have facet atropism, or did we do a good release and the facets are taking the load? And if the patient develops facet disease later, is it due to the mechanics of the device, or is it due to the phase of the disease we put the device in? So all of those go through my mind when I look at follow-ups of patients and the mechanics of all of these different types of devices. We won't go through all of these, but these are a number of biomechanical studies that were all outlined and published and well presented looking at all of these technologies. The interesting thing is you come up with a new technology and pretty soon everybody studies it around the country. Someone's looking at the biomechanics, someone's looking at the creep, someone's putting it in different labs. And we learned a lot from looking at a variety of these different studies that were performed across the board. And some of them started off like this, looking at the incident axis of rotation and where it's at and how it compares to a normal disc. And each implant looks a little bit different, so that could be a salient point. But I think to summarize, most of these technologies, these is two of them right there, the two that we have, which is the Activell and the ProDisc, they really are what Their goal was to reproduce the native kinematics of the lumbar spine, but I think the real goal is more control the disease segment in the lumbar spine than trying to restore it actually to somewhat normal as we go forward. And so we've kind of moved to this current philosophy of, do we need keels or do we need spikes? I find it interesting that one company will advocate you should use this technology for primary fixation, but a lot of times they have it because they're waiting on a patent to run out on another technology so they can develop the exact same primary fixation that someone else has. So we have to think about that in your mind when you do it. Jack is going to talk about the outcomes, but I always like to throw this slide up. And Marinus de Clover published this in the European Spine Journal going back in history a little bit in 2003. And at that time, looking at all the data and all the enthusiasm that we had for all this technology, the biomechanics, the materials, the initiations of the studies, the general conclusion was there still was insufficient data. We still get the exact same opinion when I do peer-to-peer reviews with providers today. 15 years later, there's insufficient data, it's experimental, and that we couldn't authorize such a procedure. And I think it's interesting how the vast data, we still get the same results of what people were quoting back in 2003. There has been a lot of evidence, and I won't go through any of it besides just two simple slides to show. When we ran a lot of the FDA clinical trials on this, you can see I weigh out a lot of the evidence here. Some of it was therapeutic, some of it was clinical trials, some of it was retrospective, prospective data on one implant, and the same thing that we saw with the ProDisc. And this is just a summary of them. But again, if you look at the far right, they're looking at outcomes. Most all of the historic literature in fusion is the outcome was fusion. And now we've changed the paradigm shift that the outcome is function. And so it is important for all of us as clinicians to be getting good functional data on these patients. I want to finish with just a couple interesting cases that we didn't get a chance to discuss last night. Here's a classic example of a 59-year-old gentleman that has 6-year history of back pain, complete disc resorptive syndrome at 5'1", reasonably good candidate, I think, if he's failed a lot of treatment for a fusion. He really wanted an arthroplasty. He's done very well. I've followed him now for many years of a single level. I think he would have had a good outcome with a fusion. I think that in my hands, this is probably a quicker, faster, shorter recovery. The osseous integration is probably faster than it takes to get a fusion, but that's an alternative. But what do you do in a patient like this? Tread. Dr. Treadwell, what do you do in a patient that's the third-time disc herniation with this 4-5 extruded fragment behind the body?
I would marry her and do a fusion.
But you can't, hold it. You're not supposed to have sex with your patients. Is anybody going to tell you that?
You said have sex with her.
Okay. Are you going to do the fusion first? Because then she's never going to go out with you anymore.
I would take this disc out. And
How?
Well, first of all, I would take out the back, of course. But I'm looking. I know this is an artificial disc, of course. But
Well, maybe I'm showing something that should never have an artificial disc.
right. Well, I'm taking a look. I would just take the disc out. That's what I would actually.
Third time, though.
Yeah, absolutely. She's got ridiculous.
The annulus is incompetent. It's like a tire that keeps blowing out. How many times will they let you change your tire on your Ferrari? Are you going to keep patching it?
That's a very good question. I don't have one, but I'm sure that I would just. If she only has radicular pain.
She has back pain, too. She's been this third time.
Yeah, I would fuse it.
Fuse it. You just said you'd take the disc out a minute ago.
Well, you said she had back pain. This is the third.
Well, yeah, she has back pain and leg pain.
See the X-rays. Could you show me the X-rays, please?
I don't have them.
Okay.
I only have a picture of her just so that you know who it is.
Yeah, third time. I mean, if she's got 90 to 95% of her pain is radicular pain, and she's got a third time disc herniation, I would actually take the disc out. If she's got significant back pain, she's got.
You take the fragment out or the whole disc?
Well, I don't think there's much disc left there, but I would take the fragment out. I would decompress the nerve and take the disc out.
Okay.
If she's got back pain and she's got radicular pain and she's got some renal collection extension, I would consider doing the procedure.
Okay. Jens, same? Third time disc extrusion, 49-year-old woman, just really tired of having this. A third time she's came back.
I always get asked this. I have many of those patients. If the general motion segments look intact on flexion extension films and there's a gestalt of a motion segment that makes sense to preserve, I'd always just decompress them.
Okay. Jack? So I just wouldn't want that done as a third time at this level, but.
I mean, board's answer is, you take this out and use it. TBI answer is take this out and do a PDR.
Yeah. So this is what I got to know this lady, and I think you can. I took it all out from the front, and I think when we learn to do a good release like this, and I learned that from Jack on how you put the curette behind the vertebral body. When there's an annular hole, I can usually put an angle probe like this and pull that up, and the whole fragment comes right out from the back, from the front, excuse me. And I chose to do a TDR on her. I think that's another alternative because the annulus is incompetent, Tret. It's already ruptured 3 times. It's not going to hold up. It's going to do this again. And I think this is an alternative to give her a disc. She owns a lumber mill with her husband, so you can't marry her, okay? I'm sorry. But, and I do a lot of offshore boat racing, and so I got to know her real well, and her and her husband have a boat. And so I see her not too long ago on one of the boats doing everything she wanted, and she's only pissed off about one thing. She's pissed off at my general surgeon because she hates her incision. So she fingered him just so that I could show that to Doro, so that she says, I'm going to have a plastic surgeon revise this because you did such a great surgery, but I'm pissed at my incision. So, but actually they're really a great couple, and I think that's a really reasonably good outcome. The last case I threw in is a case because Tred asked about doing these patients with these vertebral body defects like this. And here's a patient that's a dentist who sits all the time, has 5-year history of low back pain, hasn't been able to manage it. He's had epidural steroids, and you can see that he's got 2-level disease with this limbus lesion in the front. And he did not want a fusion. He didn't want me to fix his spine where he sits all the time as a dentist. And so you got to make a decision. What do you do with a guy like this? Okay, he's a professional. Do you tell him to live with it? Do you tell him to do a decompression, a fusion, a percutaneous fusion, or you do something else? And actually, at this time, I actually undersized the implant, put it all the way back. He's been years out now from that and has done extremely well. So this is probably almost more than a decade ago doing all of his activities. So now, in summary, I think that, what we learned from all this biomechanics and the disc arthroplasty world we're at today, in general, I think it's an alternative to that of a fusion. It gives improved outcomes, decreased rehabilitation, and retained motion. And we've seen these waves of enthusiasms of different types of technology for fusions, waves of different technologies for arthroplasty, and now we're looking into biologics and a variety of other things. But anytime we see these waves, we see the next wave. And this has happened immediately after a lot of discs were put in. You start seeing these advertisings of if you've had a disc in and or your family and they've had this in because they took it off the market, you call this group of attorneys. Or you call this group of attorneys because they do the same thing and they just advertise that they'll be right after these waves of technologies that we develop, and they're looking for ways to capture resources for a lot of these patients. So thank you very much.
Mike?
Yes, sir.
So again, excellent talk. This is an amazing 1-2 punch between you and Jack. So the biggest question I have for lumbar disc arthroplasty is, again, the indications. As you had identified, they're kind of a different realm from the cervical disc arthroplasties, with radiculopathy being the preeminent problem. For you, it's more back pain. Yes, there can be leg pain component involved. How far do you go for the search for the pain generator in patients with psychopathology, as we're learning more and more, maybe the overriding thing? Is discography or facet block still a de rigueur pre-requirement? Like in your dentist, would there be a reason to do a 3-level discography or something like that to try to filter out the pain, aside from the fact that it was an off-label use?
Yeah. It's changed. I mean, there were times a decade ago when that patient did have a 3-level discography, correct. But I do much less discography today than I probably did a decade ago. I mean, dramatically less. I think I use more clinical judgment. I try to find patients that have changes mechanically, no changes, no pars defect, no real facet arthropathy, and try to isolate them. But those that I don't know, then I try to use discography to rule more patients out than necessarily rule them in, or on a confirmatory basis. In our state of Colorado, you couldn't do a workers' comp patient, anyone for an arthroplasty or a axial back pain, unless you had discography. So I look at their insurance carriers because we have guidelines that are published in the state called the low back treatment guidelines. And if you're gonna do a motion preservation technology, they all have to have an arthroplasty. But that's always the black box question of who you think you're gonna get better with back pain surgery. And we all know that a lot of these radiographic findings happen in Janssen patients that don't have any back pain. So that's always the big challenge. I think the better ones are the ones that have a blown out disc or a third time disc herniation or the whole back of the annulus is destroyed because you got a morphological abnormality that I think that goes along at a higher clinical rate with their axial back pain than just stark disc disease. Do you guys do as much discography today as you did before, Jeff?
Oh, absolutely not. It's dropped dramatically to the point where I'm worried that we are losing a whole generation of neuroradiologists because they used to be so versatile and facile at it. And nowadays it's become very, very rare. How's it with you, Antoine? Oh, no, none anymore. I mean, clearly there's been a far greater refinement over the years of discography. I totally agree with it. It's a method of exclusion rather than inclusion. But here we have an extremely busy neuroradiology group, and I know of exactly one neuroradiologist who's still capable of doing it, and he's from Europe, and he's very good, but he's the last one who's very good with this technology.
You guys do a lot of discography, Jack? Or
No, we,
selective now?
we do less than before. And the subgroup of patients, at least in the PRODIS study, who did the best as far as outcomes were the 1/3 of patients who had post-laminectomy disc-based collapse, where they had pristine signal everywhere else. One disc that had a prior herniation with or without surgery was now collapsed and degenerated, and they had functionally disabling mechanical pain. That subgroup did the absolute best. They did not need discography and don't this day.
Mike, Neil Schauner.
Do you also have a similar experience that the post-discectomy laminotomy patient has a higher likelihood of beneficial outcome with the disc replacement?
I do. I think they are the ideal patient because usually you've had 1 or 2 previous discectomies and they collapse. They're easy to remobilize. They hurt. The other discs look normal. It's a completely different group of a patient that just has an MRI signal that has back pain.
And is there payer impediment to authorization of that patient?
I haven't in our state. I mean, I think there are some. United's always a challenge in it all. But our Blue Cross, workers' comp, those are all in our, they vary so much from state to state. But in our community in Colorado, that hasn't been a real issue.
In our states, lumbar arthroplasty was denied the last time. We won this famously over 10 years ago with Neil and Trent. And interestingly, in our own state, there were 0 complications. We had a very low utilization. I think we had 100, correct me, Neil, 110 patients or so done. There were no recorded major complications whatsoever. But the committee ruled against it because they had a Norwegian study that they found where surgeons did not use access surgeons, had 2 and 3 level implantations, and they had 2 deaths out of 200 patients or something like that. And so the committee decided that in light of overarching risks for patient well-being, this technology had to be denied. And this is a classic example of data mining and politics and how to use data. So it was very frustrating for us because, again, in our country, the standard of care is to have an access surgeon, and we have stayed very closely with the FDA guidelines and wouldn't or have rarely veered from it, and only in exceptional cases like yours. So I don't know what your thoughts are in terms of that Norwegian study and how to play data. The safety data in the US that we then tried to rally with against the panel here in Washington State was not of any regard to them.
It's still an uphill battle. I use access surgeon too, and it's a great relationship. Jack, any comment on that?
Europe is still pretty anti-lumbar disc replacement. I just took 2 of my fellows over for an AO course in Amsterdam. We were the only Americans there. And they were showing cases of, one guy showed a case of 3 fistulas from infected EDRs in these very heavy people with primary scars like, those are access-related issues. They just don't get it. Their mindset is very different. They're trained as surgeons first and spine surgeons, or orthopedic or neurosurgical, and spine surgeons second. So they feel they have to do this for their ego, but their access-related complications have completely change their mindset for a technology. It's nothing to do with those complications. It's a shame.
Jack, also, when we ran these clinical trials from the PRODIS, for example, and I don't have any conflict of interest on any of these technologies, personally, I forgot to put that slide up, I'm sorry. How come the two-level data never went anywhere and was never presented? Because we did run a complete clinical trial with two-level arthroplasty, but none of us thought that we were gonna need to run 1 and 2 for insurance approvals like we do today. But it just sat in a box and never went, after spending millions of dollars running trials.
Yeah, and that data was published. It was published in JBJS a long time ago, 2011. But it was just J&J made a strategic decision. I think partly because reimbursement was not good for the one level. They just didn't see the value to their bottom line of pushing through the two-level data. Sentinel now has been reworking the two-level data and representing it to FDA, and they're somewhat optimistic that there may be a breakthrough.
Even though the data is a decade old, they
Yeah,
still,
yeah.
the FDA would still.
Yeah, because that's the FDA study. That's the FDA study data.
Thanks, everyone.
All right.